So, good evening, everyone. Today is the 1768th day of uninterrupted daily webinar of International Forum for Promoting Homeopathy. And now this is the international webinar. And today's our guest is Dr. Ruta Dave, who is Associate Professor in OBGY Department at Gujarat Homeopathic Medical College and Hospital Savli and District Vadodara. Uh, she has been handling gynecopedy in GHMC Savli for 2 days since 13 years, and also she has been running on homeopathy clinic since more than 18 years, where dealt with a good number of gynecological cases. Uh, she had worked and handled many homeopathic medical camps under different associations and attended many medical camps for breast cancer screening and cervical cancer screening also. Uh, she has two scientific paper publication in international peer-reviewed index journal on gynecology and homeopathy in 2022 and 2024. She has been awarded as referral panel member and reviewer of IJITR, which is a peer-reviewed journal. And recently, ma'am's abstract was selected for presentation in AIPGHS at Parole University in November 24, and today's topic is about adenomyosis, increasing prevalence management with homeopathic holistic approach. So we welcome you, ma'am, and now over to you, ma'am.
Thank you so much, Dr. Rucha. First of all, I'll say hello, everyone. As ma'am said, myself, Dr. Ruta Dave, and uh, actually, I'm thankful for IFPH to offering me this session. Basically, I have selected a topic related to gynecology only. And if you see around us, so many of gynecological and obstetric conditions which are there, uh, frequently we are meeting with in our day-to-day OPD, or even if in seen surrounding conditions also, and which are curable by homeopathy. But maximally, it has been seen homeopathy has not been given that much importance or that much view in that. But we are having many of such conditions where the modern science of the medicine do not have actually cure or treatment, or either they are having only surgical management for that. But we as homeopath can offer in such situation cure holistic way, and that too without any surgical intervention. And we can make the life of the woman very comfortable and simple with less of her suffering. So basically, today I am going to discuss with such topic only. Basically, gynecology, where which multiple time we see that it is not much highlighted and given importance, and the topic is adenomyosis. See, if you see multiple places when you talk of gynae, so you can come with the infertility, you can come with the DUB, you can come with the fibroid, but adenomyosis has not been given so much important over here. Basically, also epidemiologically also, as well as the management level also. Uh, Adenomyosis, if you see, that is a benign reproductive lesion, right? So adenomyosis, if you see, if you ask someone what are the benign reproductive lesions, so they will say that generally about fibroid, endometriosis, polyp, like that. But no one think of adenomyosis. If a woman coming to you in your clinic at the age of between 35 to 50 years of age, having irregular or prolonged heavy menstrual period with severe dysmenorrhea, again you won't thought of the adenomyosis, but you may think of that it may be DUB, it may be perimenopausal changes, it may be a condition where the suffering from the menstrual cycle abnormalities due to presence of some growth inside, but will not think of fibroid, adenomyosis, sorry. So adenomyosis is such conditions. Generally, it has been diagnosed over the post surgical state. Maximally, whenever a lady used to have the bleeding per vaginum, which is extensive, so generally it has been said that you should go for hysterectomy. You have completed the family, so better you go for the hysterectomy. Once the hystera, after the removal, it has been sent for the histological evaluation. Over there, it may be get diagnosed that it is adenomyosis. But it has not been diagnosed as such with the condition when hystera is preserved. So let us have a little discussion on that, that we can share some of the thoughts, some of the lights over this condition on adenomyosis with its prevalence, which is increasing day to day, management with a homeopathic holistic approach. As such, I will say increasing prevalence, because nowadays the cases as such, if you see in the clinical practice, it is increasing so much. But either, as I said, it is been diagnosed post hysterectomy after the histological evaluation, or sometimes coincidentally during the USG evaluation or during the some investigations, we will go for it and we'll able to have these conditions. No doubt, I will say increasing awareness among the obstetrician and sonologist. It is early been diagnosed, and so the real and apparent both the cases increasing. But what my point is, at present we are not getting the chance to be a part of management of this condition. Say first of all, if I say adenomyosis, what is that? So adenomyosis is a benign condition whereby you can say the presence of the functioning endometrial glands with the stroma within the myometrium, and it is surrounded by the smooth muscle hyperplasia. Now I have used the word functioning because the glands and stroma may be present at the ectopic places, but they are not considered as adenomyosis or endometriosis. Only when they are functioning, they are responding to the female hormones, and they are showing the reactions towards the female hormone, where the proliferation and exfoliation would be a process in a cyclic manner, then and then only it will be considered as adenomyosis. This is an ingrowth of the endometrium in layers of the myometrium, and where actually the presence of the smooth muscles are there. So the smooth muscles are undergo hyperplasia and some amount of the inflammatory changes. As such, it's a simple condition we can consider, but it can have a substantial impact on the quality of the life of a female who is suffering from this condition. And as I said, it remains very lag behind considerably, where the non-cancerous conditions, if we discuss, the adenomyosis do not come in so far away. Maximally, if you deal with the patient also, patient will also say that there is a growth in the uterus. They think of fibroid, but they won't know, or they won't able to accept that it is adenomyosis. Even they are not doing the difference between these two. Maximally, the specimen evaluation is only the condition where we will be able to diagnose this condition. Adenomyosis, I would say, that is also known as endometriosis interna. It is one type of the variety of the endometriosis, where the ingrowth of the endometrial stroma and the gland, which is occurring into the tissues of the myometrium. It can be there over as the area where the small area has got affected, or it is diffusely affecting the whole of the myometrium. So there could be the types as diffuse and the focal, but it is still beyond neglected in comparison to leiomyomas, pelvic endometriosis, uterine polyps, etc. The adenomyosis terminology was been first given by the pathologist Carl von Rocketsy in 1860. He was first one to say this condition as elusive disease, right? But then after he worked on that, and epidemiologically when we have thought of these conditions, so the condition how it is evolving, that was the thought. See, basically, if the question arises, why does a woman suffer from the condition of adenomyosis? Right? What causes adenomyosis? Why does the myometrium that grows inside the endometrium that grows inside the myometrium? So basically, there is no any divisions, or there is no any marking line in between these two layers. They are opposing each other, but they are very nicely regulated and they do not penetrate each other. But because of some of the trigger factors, it has been found that it can be enter into the layer of the myometrium. How it can enter into the layer of myometrium? So there are few theories which are explaining it. No doubt, still 100% clearance is not there with this condition. But there is something when, as homeopathy, if we thought of something which is went wrong, and the endometrial tissue, they will try to lose their way of growth and they will enter into the myometrium. So either you can consider that is because of some genetic conditions, or it is postulated after the tissue damage or the injury at the endometrio-myometrio junction, that is known as junctional zone, that normally gives a response to the local estrogen productions, oxytocins, mediated affections, and because of that, sometimes the chronic inflammatory affections could occur over that area. So the disease in myometrium can get established. So basically, these are the considerably the factors which are predisposing to the affections. Generally, you meet with the adenomyosis when a woman is at the middle age, around the 35 to 45 years of age. They are more being diagnosed with these conditions, or either, as I said, that after the hysterectomy during this age period, and the hystero when sent for the evaluation will found the presence of the adenomyotic lesions. Parity is having the close relation with this condition, because it has been found that with the increasing parity, increasing number of the deliveries, the woman will have more prone to get affect with the condition. So multiparity, because of the hypertrophy which is occurring during the phase of the pregnancy as physiological changes, sometimes there could be possible which gives a way to the endometrium to get enter inside. Some genetic inheritance has also been found in this condition, where some of the particular genes, when they are getting activated, and because of that the affections will be occurring, though she may be nulliparous or she may be having a single child and she is suffering from these conditions. It also be resultant from the recurrent endometrial curettage. Especially, I would say that when there are frequent DNC has been done because of any reason, either for it is for the DUB conditions in the early phase of the reproductive life, or in future for the induced abortion it has been done, and recurrent endometrial curettage has been done during that period of time. Some injury to the basal layer of the endometrium, if it do occur, then the remaining functional endometrium may get enter from this vent into the myometrium, and it gets formed as adenomyosis if it gets proper response from the estrogen. So disruptions of the basal layer of the endometrium. And one more thing, what all of us are knowing, that is the proliferative activity of the endometrium that has been controlled by the estrogen. So when the estrogen is overactive, when excess of estrogen is there, or either overactivity of the estrogen is there, then also will come across with excess production of the endometrial cells, and sometimes if they found the way, and they can penetrate inside the myometrial layer, which results into the adenomyosis. Adenomyosis, as I said, the condition is increasing day by day. Nowadays, if you see, it has been seen into around 30% of the middle-aged women. So if you see the patients between 35 to 45, among the 30% females are suffering from this condition. But the adenomyosis generally coexist with other conditions also. Like it is having association with the other uterine conditions. Special association generally will be more than 60% of the other conditions also. Fibroid of the uterus associated with adenomyosis is 30%. Endometriosis associated with this pelvic endometriosis I'm talking of, that is 40%. And as general, the endometriosis externa as 20%. Endometrial hyperplasia, that has been associated with 30% of the conditions, and uterine polyps, they have been associated with 10 to 15% of the adenomyotic patients. So it is not a single existence of adenomyosis, and this is again the reason why the adenomyosis is remain lag behind the diagnosis, epidemiology, and its management course. Increasing incidents are there, but the diagnosis is actually lacking, and that is why the number of the cases which has been noted, they are not coming on the surface properly. In this condition, what happens actually and how is the structure? So I have presented two of the pictures over here. One is showing you the adenomyotic uterus picture, and the lower one is showing its histology. What happens when adenomyosis is there? So macroscopically if you see, macroscopically the diffuse symmetrical enlargement of the uterus is there. Uterus has become enlarged, and as I said, it is a diffuse variety of the disease. Rarely it is focal. So generally, the enlargement would be of symmetrical. It is more affecting the posterior wall rather than the anterior one, and that's why in adenomyotic uterus you will see the bulky uterus where the posterior wall thickness is comparatively greater than the anterior wall. It will be looking like a size of large orange. Large orange in the sense you can say there will be around 14 weeks pregnant uterus size. It do not go beyond that. On cut section, if you see, then when you're cutting and naked eye appearance, if you see of the same, so there are places where you are having some darker appearance and thickening of the uterine wall. This is happening because darker appearance because of the accumulation of the blood. Because as I said, there is a functioning endometrium. So there will be proliferation of the endometrium at the place, ectopic place, and the shading of the endometrium also will be there, but it do not have any vent to come out. So over there only it will be get stored, and the clotting mechanism and all that will be proceed. So because of that, there will be dark brownish color appearance will be there, which is diffusely scattered in the form of spots or gatherings, and thickening of the uterine wall, that is will be seen because the endometrial tissues and the blood which is present at the ectopic place. So the surrounding myometrial cells, they will give reaction towards, and that leads to the thickening of the wall. Characteristic trabeculated appearance will be there, visible cystic dark places and blood spots. The lower slide which is showing you the appearance, that is trabeculated appearance. So there is the formation of a trabecula will be seen in this, and where there is an accumulation of blood as well as some of the cystic dark places. If you see structurally, histologically, it is showing the presence of the glandular endometrial tissue surrounding by the stromal cells of the myometrium. See, this is one of the laparoscopic picture has been taken for this condition where the spots which have been there, this is a uterus actually, and the spots which are there, dark colored purplish brown spot which are there, they are the sites where the endometriosis has occurred. This is one picture which is showing you the presence of the endometriosis evident on the laparoscopy, and second picture, that is a slide where how if you go for the cut section of the uterus and how will you see the condition, that is been shown over here. So basically we will say there are so much of the collection of, and as day passes, the endometrial cell, they will proliferate, the number of the cell increasing. Because of that, the shading of the endometrium at the ectopic places, that is also increasing, and slowly and gradually it increases in the size. The size would become slowly and gradually greater. So this development of the adenomyosis, that takes couple of the years. It takes longer period of time, and because of that, you'll be having the diagnosis or the symptomatology which comes, that comes really very afterwards. See, these are some more pictures where three pictures together have taken. First one that is showing you the adenomyotic uterus on the hysteroscopy. Second middle picture, that is a specimen of the adenomyotic uterus. And third one that is showing you the difference between the focal and diffuse adenomyosis, which is evident over the MRI. These pictures are showing you the severity of the conditions, the growth of the tumor that is occurring at the level by endometriosis interna, right? So how it will represent with the clinical entity, what will be the symptoms patient will approach to you. So as general gynecological consideration, if I say, the patient generally would be middle-aged patient. 80% patients are between 35 to 45 years of age, and among that 90% woman, she is parous, generally multiparous. As the parity increases, the rate of affection is also increases. History of recurrent abortion or curettage also may be associated when you take the history of the patient, past history or the obstetric history of the patient, where you may come across with the recurrent abortion or the history of the curettage for some particular purpose, and you may conclude it as a parous woman, and this may be one of the cause which can be there for the development of the adenomyosis in her, that particular female. On further, if I go, because as we said, there is a presence of endometrial ectopic tissues into the myometrium. So myometrial contractibility will be get affected. Myometrial contractibility, when it has been getting affected, so dysmenorrhea, will consider dysmenorrhea will be the major symptom associated with 35 to 40% of the cases, and when the 80% of the depth of penetration, the pain increases, pain becomes severe. So as the day passes, she is having a complaint of dysmenorrhea up to some particular magnitude today, and after 2 years she'll be having the greater magnitude, which is increased a lot because of the increased penetration of the ectopic endometrial tissues into the myometrium. Chronic pelvic pain, because of the same, she is having constant dull aching discomfort in the lower uterine segment, lower pelvic region, that she always feels some heaviness over the area with some discomforts, because the contractions which are coming in order to remove this ectopic tissues, but they do not go away because already they have got implanted over there. So the pain goes on, and with the fluctuations of the hormones, with the secretions of the estrogen, prostaglandins, and the luteinizing hormone, the dysmenorrhea will be increasing over there. Now, 70% of the females will show you the symptoms of hypermenorrhea. Hypermenorrhea, where you can consider the heavy menstrual cycle. So either the menses will be very much prolonged, it continue for 10-15 days together, or even it can be continue from one cycle to another cycle, or though it is of 8 to 10 days, but it is having so heavy cycle, like she will narrate you the symptom as if that I'm having so heavy period that I need to change 10 to 12 pads in a day, and that kind of the flow is continue for at least 6 to 7 days, and I'm getting debilitated off, so the blood loss is much more heavier. Why does this is happening? This is happening because of the increased surface area of the uterus. See, when there is a growth of the some extra growth which is there in the myometrial layer, that much layer of the uterus is increased. The size is increased, surface area of the endometrium is increased, and because of that some more amount of the bleeding is there. Second one, the contractibility of the muscles have got affected. So the musculature which is having the living ligatures in between, the vessels which are passing through, that will not get proper effects of the contractions, and the contractions which are coming during the menstruation, that remains halfway, As a result of that, the clotting mechanism will not be get activated over that area, and it continues for the longer period of time her to bleed. She may have irregular menstruation also. So it's just not the hypermenorrhea. There could be possibility of the metrorrhagia also. There could be possibility of the epimenorrhea or polymenorrhea, or there is an association of epimenorrhagia. Again, as the growth increases and it is diffusely occupying the posterior wall, so it may interfere with the sexual function of a female and leading to the dyspareunia in the female when growth is become such an adequate size that even it can obstruct a portion of the vaginal canal. Above and all, there could be, because of the increasing weight of the uterus, there could be frequency of the micturition, as if what we noticed in case of the early pregnancy, right? That because of the pressure from the gravid uterus, it causes the frequency of the micturition. The same thing would be over here also, because the myometrial thickening is also there, and parallelly myometrial layer is also containing the portions of the endometrium, which is become like a tumor, because over that area the shading of the endometrium is there and it gets clot over there. So clot is always having the more weight than the normal blood, and cycle to cycle it is increasing. So as day passes, the pressure over the uterus that is increasing, and it leads to the frequency of the urination. As a result of that, implantation failure is also one of the thing which you will come across with. And nowadays this is one more place where you can come across with the diagnosis of the case, because infertility is so frequently complained in the day-to-day gynec OPD at present. And infertility, when you try to search for the cause, and if you simply go for the ultrasonogram of a female, there is the presence of adenomyosis can be get noticed over this area. There is hyperreactions, inflammatory changes which have been there into the muscle layer of the uterus. Contractibility has got changed. The endometrial tissue has become more responsive towards the estrogen, and there could be hyper secretions of the estrogen, or hyperactivity of the estrogen is there. As a result of that, the implantation would be get affected, and she might be suffering from infertility. So it coincidentally get diagnosed during the investigations of the infertility is also possible in the day-to-day OPDs in current era. Miscarriage. So patient will also come with the complaint of recurrent pregnancy loss. And when you go for the investigation, you might be able to diagnose under the USG with the same condition of adenomyosis, as I talked to implantation failure. Other than that, as we said, there is hypermenorrhea. So obviously there is so much of the blood loss, and the prolonged cycle is there, continuous blood loss is there, which will not be get compensated, and as a result of that she suffer from varying degree of anemia also. So you will have the signs and symptoms of the anemia. With that, weakness, yes, obviously would be there. Concentration will be difficult. Fatigue will be there. She may become irritable up to the extent because of her sufferings and because of the continuous bleeding. And as a result, what happens that maximally the condition remains underdiagnosed, and people will go for that. So much of bleeding is there. The general condition is deteriorating. Better to go for the hysterectomy. General approach would be like this. That is from the patient side also, and I have found the same is from the gynecological side also. So first among it, that the condition we can diagnose when we go for the examination of the patient. So whenever some patient come to you with a complaint of heavy menstrual cycle, don't miss the diagnosis. You may get the findings if you go for the per abdominal examination. Some midline hypogastric mass may be arising from the pelvis. This should be differentiated from that of the pregnancy, because she is into the reproductive age. So might be possible at this age she is pregnant, and the hypogastric mass is a pregnancy, early pregnancy. But that is one finding which you can have, because as I said, it do not exceed more than a 14 weeks pregnant uterus size. So it will be a little higher than the pelvic margins. It is just entering into the abdomen. So when you go for the per abdominal examination, you can feel some mass which is arising from the pelvis, and it is lying into the middle of the lower pelvic region. So it is better you go for the pervaginal bimanual examination. So pervaginal bimanual examination, yes, where you can find out the diffusely enlarged uterus. The uterus is quite larger than the normal size of the uterus for that age. And it is softer, bogey in the nature. Like when you have the consistency feel, it is bogey in the feel. The uterus is suggestive of adenomyosis. Apart from that, the growth which is arising from the pelvis, how you will confirm that whether the growth is from the uterus or whether it is from the appendages or whether it is from any other parts or organs of the lower pelvic region. So when you try to catch hold the cervix with the valsalum, and if you try to move the cervix, the growth will move with the movement of the cervix. In the same direction with the same movement, it will move. That indicates the growth is arising from the uterus. You can go for the rectal examination for the confirmation of the diagnosis, what you have done from the vaginal examination. In these conditions, as I told, the ultrasound has been considered nowadays the earliest diagnostic technique, because it is so frequently available also, it is cost effective also. So maximally patient will easily go for it, and maximally obstetricians they are having in their own clinics. So over that it can reveal what are the findings in the US which we can observe. Suppose patient comes to you with this film, that what we can found. So we can found the presence of the thickening of the uterine wall. For the first thing, the uterus thickness is greater, the size of the uterus is greater. Uterine wall that is thick with the indistinct line. You will say that it is Venetarian appearance. Other than that, there is heterogeneous myometrium with echogenicity. There is presence of echogenic myometrium. Why there is a presence of echogenicity? Because there is a functioning endometrium is there. Like black pepper, if you crush and if you spread it into the single layer, the kind of this structure will be seen in the myometrium. This is actually showing you the presence of the endometrium with the blood supply. So that echogenicity will be there. Presence of the blood spots will be there surrounding, and the signs of this all signs, if you get together, they are suggestive of the adenomyosis. But again, I'm repeating, they are suggestive of, they are not confirmatory for the adenomyosis. But yes, MRI has been considered as gold standard, normally not been practiced. Where the JZ junction, I told you the junction which is in between the myometrium and endometrium, that is known as junctional zone, like which is actually vulnerable, and this zone become thickened more than 12 mm, and this is what you will consider as the truly diagnostic for the condition of adenomyosis through MRI. Other, you can even go for tumor markers which are not actually so much diagnostic, but yes, biopsy can be taken for the ruling out the malignant lesions. You should also go for the general routine examination, especially CBC, because as we say, the patient will suffer from anemia. So you should go for that. Most nearer differential diagnosis for this condition is fibroid. It is maximally been considered as fibroid in the layman's language. They are thinking of that is a tumor in the uterus. That is a single line, and what has been interpreted for the leiomyomas. But when adenomyosis is also there, they are also thinking that it is a tumor of the uterus. So just have a differentiating point between two: fibroid, which is arising from the myometrial layer of the uterus. It is a tumor of myometrium. Whereas endometriosis interna, that is adenomyosis, is a cyst or a tumor-like structure which is arising because the endometrial tissue which are ingrowing into the myometrium, and they are present in between the layers of the myometrium. And that is why the leiomyomas, if you see, it is having the pseudo capsule against it, whereas the adenomyotic lesions, they do not have such kind of the capsulation. So they are not non-capsulated lesions. Fibroids can be very small, like green pea size, or even they can be as larger as 6 months pregnancy also. They are generally there present into the myometrium, and they can be get pushed inside and outside. So they can become subserous, so they can encroach the cavity, or they can be out from the uterus, and they can move into the outer side of the uterus in the surrounding peritoneal structures. Whereas this particular lesion that is constantly been present into the myometrial layer only, and the size do not exceed more than 14 weeks of the pregnancy. In case of the diffuse variety, if you see the enlargement in case of the adenomyosis, where you are having the symmetrical enlargement. See, both of the lesion, leiomyomas and the adenomyosis, both are occurring more to the posterior wall. But fibroids, they are actually space occupying lesion. They are present at some particular places, so the irregular enlargement will be there. Whereas in case of the adenomyosis, maximally you will find the symmetrical enlargement of the uterus. Leiomyomas, they are containing the smooth muscle fibers and fibrous connective tissue as a structure, whereas in case of the adenomyosis, you are having the presence of the functioning ectopic endometrium with gland and stroma. Myoma, when you see on the cut surface, the myoma is white in appearance, whereas adenomyosis, we say that it is darker, having the dark occupied spaces like a cyst, and there is a presence of the blood spots also into that. You should also differentiate this condition for the other varieties of the endometriosis or the hyperplasia of the endometrial lining that could be resulting into DUB or some endometrial polypoidal growths also. Now we come to the management of this condition. See, as I said, that you can go for clinical diagnosis, you can go for the histopathological diagnosis, you can go for the imaginary methods of the diagnosis or radiological diagnosis also. But what finally comes? So in case of modern science of medicine, if we see, the maximally they will manage in the beginning. If they are less symptomatic, they will try to supply it with some painkillers, non-steroidal anti-inflammatory medicines, or the combination oral contraceptive pills, or GnRH agonist like leuproid depots can be given, or antagonist can be given, or simple progestin can be given orally, right? Or they can suggest for the levonorgestrel intrauterine contraceptive device to control it. See, what is basic phenomenon that to control the functioning of the ectopic endometrium. Even you can go for the artificial menopause in this patient, that temporary menopause or the pseudo pregnancy, if it has been planned, means you will give only progestin and you can control the growth of the endometrium, and the ectopic tissue will not further grow and they will undergo regression and the condition will be cured. This has been expected. Oxytocin antagonist also can be used. But maximally in practice, if you see, once a patient has been diagnosed with this condition, directly been advised with the removal of the uterus. And suppose the patient comes to you with the 2 consecutive cycles of the heavy menstruation, then generally it has been advised by the specialist that you should go for the hysterectomy, removal of the uterus. Patient also feels same. Patient also feels that once the uterus is out, there is no question, I will not have the further menstruation and my problem will be get solved. They are not knowing the sequelae of the hysterectomy. They are not knowing the post effect of these conditions, and that's why they are finding this safest and easiest solution. If suppose some patient where it is required to preserve the fertility, so they will think of the resection of that particular area. So uterus preservation resection or the myomectomy, that affected portion of the myometrium with the ectopic endometrium will be get removed and the remaining function will be get preserved. One more which we can go for, that is umbilical artery embolization. So the supply will be get affected and automatically the destructions will be there. you can go for the temporary suspension of the menstruation for months together so that the ectopic endometrium undergo regression. There are also some therapy like radio frequency ablation can be applied, and high intensity focused UST. That is also the latest method by means of which the ectopic endometrium in the early phase can be get destroyed. But see, when we talk as homeopath, right? So as a homeopath, we think about the holistic approach. We think that we should treat the patient as a whole and there should be preservation of the organ. We are not actually in the favor of surgery in all the cases. So, according to the classification, also we are having only few cases which are truly surgical. And when I talk of adenomyosis, from my clinical experience, I'm sharing that there is marvelous result we can get from this condition, because adenomyosis, where you are having one, that is, you can offer two-way treatment in this condition homeopathically. One, where you will treat patient as a whole and you will try to destroy this ectopic endometrium and normal functioning of the uterus can be get resumed, or at least you can control the further activity of the ectopic endometrium. But the second very baseline management which you can do, that is, you can go for the symptomatic relief. That when there is a excessive hemorrhage, menorrhagia, or severe dysmenorrhea which is there, see why patient is selecting hysterectomy. The reason to select the hysterectomy is the day-to-day suffering. Either she is having so much continuation, prolongation, and heavy menstrual cycle. So she will think of, I want to read off this thing. Or either she is having so much of this severe dysmenorrhea. Then also she will think of that every cycle I need to suffer from this, better I should not be with. It is a solution that I shall go for the removal of the uterus. And family also will think of that why, because women, we will consider the most neglected in the female, especially for their reproductive sufferings. Why do you suffer from this all things, others are not suffering, and why do you suffer from this? Okay, it's fine, menses is there, but why the so much of pain is there and you are just pretending it? And because of this all reasons, finally patient reaches still to the level of hysterectomy. Now, if even we offer the symptomatic relief, especially we control the dysmenorrhea, we control the hypermenorrhea, we can rectify the level of the hemoglobin percentage and recorrect the anemia. So definitely patient will show the faith in our system, and further we can continuously manage with the condition and the adenomyotic affections will be get controlled and cure up to the extent. I have enlisted few of the medicines over here because we homeopathically, when we believe the constitutional medicines are being indicated for such kind of the conditions maximally, when it is covering as a whole, miasmatic approach also to be considered important, where the psychosyphilitic miasm are more coverage. But there are many medicines. I have just enlisted few among that which can be helpful in these conditions. And these medicines which I have shared, among that few I have utilized on my patients and have got marvelous results with their patients especially. I have one very good case of Calcaria carbonica, young female, third para, and she has extensive menstrual cycle which is continuous cycle to cycle, and she has been advised by the gynecologist to go for the removal of the uterus. She is one of the staff of our college hospital, and she came to me with the report. I said, you should not go for this removal and just give me 6 months. And by third month, she developed her normal menstruation, which stops by itself, and she did not have heavy cycles. She even not having any pain. And after, I think it is 2-3 years back, I'm talking of. And today, she is not having any symptom. And even I have withdrawn with the medicine also. The adenomyotic lesion also shrinked a lot and it has become completely asymptomatic. See, this is what we can offer to the patient, and once it becomes asymptomatic, patient will be happy. And even there is no question whether they continue with the medicine or not. Actually, they continue with the medicine. We can have an evidence that we can even cure with the adenomyotic lesion. Like I have one case with the phosphorus also, which shown finally the result of she is a female from the Muslim community, and she came to me with a complaint of infertility. She want to conceive after the second child because both of the previous child was female. In this, she was came with me, and I have sent her for the investigation because she had heavy menstrual cycle. I sent her for the ultrasonogram, and she concluded with the diagnosis of adenomyosis. Her age was 35. And when I started with the phosphorus, her menstrual cycle was regulated from very next cycle, and even the adenomyotic lesions started decreasing in their size and appearance. And after somewhere 7 years, when once she had again the heavy menstrual cycle, I asked her to go for the USG again, and it was again the marvelous effect of the homeopathy. There is no adenomyotic lesion. What I mean to say is there are so many medicines by which we can control not just the symptoms of the adenomyosis, but the growth, further growth of the adenomyosis also, and their functioning at the ectopic places. This will be our great contribution to the field of the gynecology if we can be capable enough to show these evidences to the patients, if we can show the testimonials of the patients, and where the community be aware of our system, that we can give the cure, we can provide the holistic relief to the affections where no other system can offer these conditions. Yes, of course. Obviously, people will divert towards us. And I have found one more thing also. Nowadays, gynecologists are also in opinion that they will also go with the additional treatments, where they will use as additional treatment, they will use some Ayurvedic or homeopathic treatments also. And so we can even go for the this conjoined treatment also, where we can club with a gynecological clinic, and where we can function with their medicine, even we can continue with our medications, and we can cure these conditions. I think for today, this is enough what I can share with you people. And yes, of course, I was actually eager to share some cases also, but the time do not permit for it. So we'll have some other day when I can show you the evidences of the cured cases also. But at the last, I would like to request all of us through this medium of International Forum of Homeopathy, where the not just the doctors, but yes, patients are also can hear this. So we are having many of the conditions in all the gynecological and obstetrical complaints where the cure is possible, not just the treatment, the cure is possible. And it is our prime duty maximally that we can guide our patients, divert our patients, and make them compelled to take the homeopathy, so that we can, and at least uplift the standard of the life of a female also. Thank you so much for giving me this opportunity and making me part of the forum and the lectures. If someone want to ask or discuss something, please let me know. Thank you.
Excellent session indeed, Dr. Ruta. It's really,
Thank you, sir.
Frankly speaking, these kind of presentations are really in the need of the hour, because we need to show the world that homeopathy can do such wonders with our medicine. And as a homeopath, I'm very happy, very proud to see such presentation in this forum. We have seen lot of doctors and eminent professors coming over here and presenting such beautiful cases. And as you rightly point out, we hope that you will come up with some cases, because only when, as and when the cases were presented, people will get into the idea that homeopathy can do such wonders with gynecological problems also. As you mentioned a case here in from your college itself, that show the power of homeopathy. As we all know that the secondary infertility is one of the area where homeopathic doctors can do wonders. We have a lot of doctors in Kerala who are having such known as infertility specialists, particularly Dr. Remadevi Ambadi, Dr. Shanta Chandran, Dr. Dilip, and all those people are very dynamic personalities who are having more than 1,000 to 2,000 cases in their kitty. Successful cases, as we all know that those cases coming to homeopathic side are really struggling a lot from they are finding it very difficult to manage cases from the treatment from the other side, because they are cost very high cost. They are having very high cost, as well as they are trying a lot of steroid upon the person, and still they are finding it difficult in getting the a solution. And then that means at the last stage, people come to homeopathy. So we can, what the purpose of this forum is to make people aware that homeopathy can do these things, and so that those who come early to homeopathic doctors can will get success in the shortest possible time. Am I right, doctor?
Yes, of course, sir. Actually, I have found that nowadays people are aware of homeopathy, but we shall increase this awareness by showing our range in this kind of the lesions also, because they are knowing we are only limited to some of the conditions. And gynecology, generally, I found that is remained untouched area maximally. By even if you see, we are not having PG in the gynecology, we are not having the specialist in gynecology, and that's why it remains some lag behind that gynecology and obstetric. I can say that I am practicing in my college only with, because it is in the rural area where so many of the antenatal cases are coming, and they are suffering from many different affections also, but we are just managing them with the truly homeopathy. No other treatment is there, and we can give a marvelous result for everything, even the growth and development of the fetus also.
Yes, exactly. This is in the early part of this career, we find that people believe that homeopathy is for children treatment, but things are entirely different now. People know that homeopathy can do these things because a lot of people coming over in in the YouTube as well as in different medias and showing the world that homeopathy can do so such and such cures, whether it be a case of infertility, whether it be a case of cancer, whether it be a case of hypothyroidism or thyroid disorders, whatever may be, or peptic ulcer. So that means we all know that all homeopaths are supposed to be a multi-specialist, and while treating different kind of patients, sometimes we may get results in infertility in a successive order, so that that person will literally known as a infertility specialist, and a person who is expert in managing piles will known as oh, he is a very specialist in that area, like that. This is how the specialists are born in homeopathy. Nowadays, we have pediatrics PG in different colleges, but
Yes.
this kind of because homeopathy is a system which is entirely different from others. That's why we are doctor. We used to say that we are doctor specific as well as patient specific, and not a particular disease specific. That is why homeopathy. That's a different aspect of homeopathy, and that's the reason why we may have the people in Delhi who are setting the time educational calendar are not producing such a specialization in gynecology, orthopedics, or even ENT or I specialist, because homeopathy is entirely different system. That may be the reason, but still a homeopathic doctor or physician can become a infertility specialist or even a cancer specialist by treating a lot of such cases. So you particularly the doctors from our lady doctors are so brilliant, and you people can do much better in this area. So my request to all of you is that you should concentrate more on gynecological problems and show the world that homeopathy can deliver a lot of good thing for the womanhood.
Of course, sir. Actually, we are getting the references from obstetricians and gynecologists also. Now they are also accepting our system that it can work and we could be helpful where they do not have any option.
If yes, exactly. If anyone want to participate in discussion, please raise. Dr. Mrs. Shastri, somebody. If you want to talk to Dr. Ruta, you may raise. You may unmute yourself. You just click on that left corner. You can unmute yourself and speak. Dr. Ruta.
Thank you, madam. Thank you, Anandal. Actually, what she narrated, the adenomyosis as well as fibroids and pertaining to the uterine disease and DUB especially, very, very useful to clinicians who actually prescribe on clinical basis. It is very excellent explanation and very thanks to her, and I am very thankful to the nice explanation. Please continue in the next session also if possible on different aspects of uterine diseases. Thank you, madam.
Thank you so much. Thank you so much, sir.
Thank you.
Yes, if you, Dr. Rija, Avedya, you can speak.
Yes, sir. I have one question regarding potency and repetition criteria.
Okay.
Ma'am, can you please throw some light on this?
Yes, of course, ma'am. Actually, as I say that it is on the constitutional based prescription, but when we treat symptomatically, so sometimes we need to go for the frequent repetition for controlling the hemorrhages, to control the dysmenorrhea pain. And even I have found the water potency will be more useful even because it can give the frequent repetition also, and we will not provide the massive dose also, so the aggravation will be get avoided in this cases. But else otherwise, if you want to go for the thorough treatment of the adenomyosis for that patient, then constitutional prescription do not require more frequencies of the repetition. So that depends on the selection of the medicine, acceptability of the patient, that you will decide your repetition of the dose. Apart from that, sometimes you need not to go for the repetition even in 15-20 days or even monthly cycle. Only one dose is also sufficient in them.
Okay, thank you, ma'am.
Thank you so much.
Sir, should we conclude the session now?
We can invite Dr. Sairiga for RUTA. Thanks. Dr. Sairiga? Yes, Dr. Bob?
Hello. I start my video. Okay.
Yes,
It has been an honor for us tonight to have Dr. Ruta Dev, his assistant professor in gynecology and obstetrics, and for presenting a very successful 1,768 webinar on the increasing prevalence of adenomyosis. Adenomyosis is very prevalent nowadays, and it causes a lot of infertility for the population. And it is very good that we have the management with homeopathic approach, a truly holistic approach, which is presented by Dr. Ruta tonight. And she has been very technical and a very detailed presentation of adenomyosis. So we hope to hear from her in the near future, because there are many case taking which she would like to present to us, and we will be very, very happy to witness her successful case by in adenomyosis through the treatment of homeopathy. And on behalf of IFPH, I'd like to thank her once again for this successful presentation tonight. Thank you.
Thank you so much, sir.
Thank you, Dr. Bob Lim. Thank you, Dr. Ruta Dev and Dr. Mavaidya for excellent moderation, and those who participate in the sessions also. Tomorrow we will have a session from Dr. Prakash Rao. He's a former research officer, CCRH, and he has presented a lot of present papers on research on his research work in different subjects. And tomorrow we'll be talking about genus epidemicus and its research. With that, we come to the end of the day 1768. Thank you all. Good night. It's over to Dr. P. Shaila to moderate the session. And before that, the video of the same will be uploaded tomorrow itself, so that those who want to share it can share. Even you can share it with, you can subscribe the same without paying any money. And you can share it with anybody, whether it be a homeopathy lover or a student or whatever may be. Thank you all. Over to Dr. P. Shaila.